Okay, the respiratory system. So our structures of the respiratory system, we were talking about the nose, into the pharynx, the larynx, the trachea, into the bronchi, down into the lungs, and lastly the alveoli. The mouth is technically also part of this, but we'll come back to the mouth when we do the digestive system. So we're going to lean more into the nose for the respiratory system. So let's know the components. Functions of the respiratory system. Of course, to supply oxygen. To eliminate carbon dioxide. We use it as a pathway to get air in and out of our lungs. The big one, to filter the air, to humidify the air, and to warm the incoming air as it moves into our lungs. Gas exchange. The receptors for smell and for producing vocal sounds. So these are all various functions of the respiratory system. Now, structurally, we can divide the respiratory system into two categories. We've got our upper respiratory system, and with that, we're talking about the nose, the pharynx, the larynx, and their associated structures. Now, a lot of people will just classify the nose and the pharynx as the upper respiratory, and they'll actually move the larynx down. I just like to split it because the larynx is right there, right beneath the pharynx. So it's all applicable. Our lower respiratory system, the trachea, the bronchi, the lungs, and all of their associated structures. So know what we find in our upper and our lower respiratory system. Now, functionally, we can divide our respiratory system also into two components. The conducting zone, which is going to go from our nose to the terminal bronchioles down in our lungs. And this is really the pathway to move gases into or out of the lungs. So the conducting zone, we're conducting the air down into our lungs or back out of our lungs. So the structures that we have to go through. Our respiratory zone, that's going to go from our respiratory bronchioles down into the alveoli, and this is where gas exchange actually occurs. So conducting zone is all about moving air. Respiratory zone is gas exchange. So let's know where they run. That's probably the main thing here. Conducting from the nose to the terminal bronchioles, the respiratory zone from our respiratory bronchioles down to the alveoli. All right, our first structure, the nose. So with the nose, we split it up into three main components: the external nose, the nasal cavity, and the paranasal sinuses. And we're about to look at those in a little bit more detail. So our external nose. Two openings called the external nares or the nostrils. So when you see someone picking their nose, they've got their finger jammed up. Their external nares is the term that we want to know. External nares. Our external nose, we split into two distinct pathways using the nasal septum. So I've got a left side and a right side because of that nasal septum. These passageways lined with hairs to help act as a filter for some of the larger particles before they get too far down into our respiratory system. We actually have two types of hairs in our nose. We got cilia, which are the super small hairs, and they wave back and forth to catch the really fine particles. And then we got vibrissae, which are just the longer, thicker hairs that stop the larger particles. So vibrissae, the bigger hairs for bigger particles. The cilia, smaller hairs for smaller particles. And so note on the picture here that we have practical listed in the bottom right hand corner. So this is a picture, or at least this information we need to be familiar with for the practical exam. You need to be able to distinguish the difference between cilia and vibrissae. Now, our framework to the nose. I've got a bony framework and a cartilaginous framework that both play a component into it. So with my bony framework, what I want to know, it's the frontal bone, the nasal bones, and the maxilla. With my cartilaginous framework, I want to be able to recognize the septal cartilage, the lateral nasal, and the alar cartilages. So we see this is going to be on the practical exam, or a picture very similar to this will be on the practical exam. So let's know what bones we're talking about and what cartilages we're talking about when it comes to the nose. So our nasal cavity. This is going to be between my external nose and the pharynx. It has three shelf-like partitions that extend out. We call them concha. The rest of the world calls them turbinates. but we call them concha, so that's what we'll go with. So I've got a superior nasal concha, a middle nasal concha, and an inferior nasal concha. So let me be clear. The concha are the shelf-like partitions that stick out. And what does is that kind of funnels the air through these passageways that run underneath the concha. We call these passageways the meatus. So I've got a superior nasal meatus that I'm going to find under my superior concha. I've got a middle nasal meatus that I'm going to find under my middle concha, and an inferior nasal meatus under my inferior concha. So air has to flow through this meatus because the concha stop it otherwise. So there we can localize a lot of the hair and a lot of the mucous membranes to help catch any particles before they get too far down. So I said the rest of the world calls them turbinates because as we breathe in through our nose, that causes the air to circulate really fast inside of our nasal cavity, and that causes and throws all of the fine particles like the dust and the pollen and stuff. It throws it against the wall of the nasal cavity, which is super sticky because it is a mucous membrane, and that helps trap a lot of these particles, and that's also how you make a booger. It's just all of the stuff that is being thrown against the wall of your nasal cavity. All right, some paranasal sinuses, system of hollow cavities into the skull. All of them drain into the nasal cavity. There are 4. So I've got my maxillary sinus down at the maxillary bone. Remember, that's your upper teeth bone. I've got the frontal sinus at the frontal bone, the ethmoid sinus kind of in between the eyes, and then I have the sphenoid sinus also kind of in between the eyes. So those two can be a little tricky. But the sphenoid sinuses kind of lay behind the ethmoid sinuses. So they function to produce mucus and contribute to voice resonance. With resonance, we're just talking about prolonging, amplifying, or modifying a sound by vibration, and that is resonance by definition. So a couple of things we want to be familiar with for this slide specifically. We need to know the definition for paranasal sinuses, so hollow cavities in the skull. We want to know what are the 4 sinuses. So maxillary, frontal, ethmoid, and sphenoid. We want to know where each of those is located. We have to be able to identify that on a picture because we can see it says practical exam. And then let's know what resonance is, the definition for resonance. All of that is good information. Into the pharynx. The pharynx, of course, is also known as your throat. Muscular tube, about 13 centimeters long. I would be familiar with that. Again, we have 3 regions to our pharynx. I've got my nasopharynx, my oropharynx, and my laryngopharynx. So my nasopharynx is just the part of my pharynx that's behind my nose. The oropharynx is the part of the pharynx behind my mouth. And then the laryngopharynx is the bottom part of my pharynx. It's behind the larynx, essentially. So with my nasopharynx, what I want to know about my nasopharynx, 2 things. It runs from my internal nares to the soft palate. So we said the external nares was your nostrils. That's the way to get into your nose. We call them the external nares because they are the most external ones in your body. My internal nares is the passageway out the back of my nose. So if you look at our picture here, we've got our nasal cavity with the concha, the shelf-like partition sticking out behind that. But before it turns blue, that little region where it narrows, those are my internal nares. My internal nares. So it's going to run from my internal nares to my soft palate. That's what we want to know about the nasopharynx. Internal nares to soft palate. And we also want to know that it has openings to the auditory tube, which we can also see in that blue area up there. All right, so we've got a middle portion, which is going to be my oropharynx. We can see that in green. And it runs from the soft palate down to the hyoid bone. Now, our middle portion with the opening to the mouth is called the fauces. So just like the back part of our nose that leads into our pharynx is called the internal nares, the back part of our mouth that leads into our pharynx is called the fauces. And we'll see that again in the next chapter as well. All of the pharynx we'll see again in the next chapter as well when we're talking about the digestive system. And then lastly, we got our laryngopharynx. The lowest portion here, we can see it in purple. It runs from the hyoid bone down to the split. So the split is where we're going to make the decision to either go into the respiratory system with air, or we're going to go down the esophagus, down to the digestive system through the esophagus. So we have that decision to make at the bottom of our laryngopharynx. So if it's air that we're swallowing, or inhaling, it's going to go down the respiratory system. If it's food, we want that to go down the esophagus. So let's know the components and know where they extend when it comes to our pharynx. So this is a picture. I will use this exact same picture again in the digestive system, so spend some time with this one. We can see this one has the external nares marked for us, my concha marked for us, our meatus marked for us in the nasal cavity. I've got my paranasal sinuses through here, at least a couple of them anyway. I've got my internal nares blocked for us. They call it the internal nares, but it's the same thing. And then my fauces is also labeled for us at the back of the mouth before we move into the actual pharynx itself. Also make sure you pay attention to the picture on the right that has the yellow, blue, and orange regions. That's just an easy way to ask about the various parts of the nasopharynx. The pharynx, excuse me. All right, so as we leave the pharynx, we move down into the larynx. The larynx is also known as your voice box. It's located between the pharynx and the trachea, of course. It's at the top of the neck, involved in breathing, producing sound is probably the biggest component, and protecting the trachea against food aspiration. So our larynx plays an active role in keeping food out of our digestive system. Food and liquid, when we're eating or drinking, all of that ends up in our digestive system thanks to our larynx. It houses and manipulates the vocal cords for pitch and volume in the process of phonation. So the first major part of our larynx I want us to look at is the glottis. So the glottis is really just an opening between the vocal folds in the larynx that we think of as the primary valve between the lungs and the mouth. So the glottis is an opening between the vocal folds. It is the primary valve between the lungs and the mouth. And we can see that in our pictures here, in both pictures, the opening that extends down into our respiratory system, the glottis. All right, vocal folds. So I've got two sets, really, of vocal folds that we associate with the larynx. I've got my ventricular folds, and these guys allow you to hold your breath, but they don't produce any sound. So we call these the false vocal cords because they're right there with it, but they don't make any noise whatsoever. The other set, the lower set, is my vocal folds. And so as air passes through these folds, it produces sound. This is the process of phonation. Pitch will change, which changes in tension. So the higher the tension, the higher the pitch. The lower the tension, the lower your pitch. And so when I was learning this, I would always say vocal folds. Vocal folds. And I would make my voice deeper or lower specifically is what I was going for. I've got my ventricular folds and my vocal folds. Because if you look to the picture on the right, this is a great picture showing a cross-section. They have it labeled as a sagittal section of the larynx. And we can see we've got the two sets of folds right in the middle, the ventricular folds and the vocal folds. And so I always made my voice lower so I know which one was on the bottom so I wouldn't get them confused. So vocal folds is the lower one, so that's why I make my voice lower when I say vocal folds. All right, so yeah, make sure we know this picture. It's not, why is this not marked as practical? Oh, it is. Okay, on the left-hand side. Good. Moving on. So our vocal cords are really triangular pieces of skin, so the term vocal folds just applies better. And remember, this is the opening between the folds is the glottis, so that's where all of the air is moving through. And so we've got some noises we can make. We got the glottal stop is where we say things like uh-oh, where we have to stop the vocal folds. Or stop the sound, and we do that quickly by closing our vocal folds, and that stops the flow of air from vibrating it, so we can move on to the O portion of uh-oh. If we say ah, this is where we're going to hold our vocal folds close together and vibrate them. If we say s, that's our voiceless sound, where our vocal folds are just held open. We're not trying to vibrate them, we're just holding them open. If we say zzz, like a B, that is one where we do vibrate the folds. All right. Now that sound is actually being produced. We're pushing air through our larynx, vibrating those vocal folds, and we are producing sound. But now we have to be able to manipulate that sound into words. And to do that, we've got a few different types of articulators. So the tongue, the lips, the teeth, the hard and the soft palate together, and the uvula all help us articulate that sound and move that sound, manipulate that sound into forming the individual words that we make. Phonetics is just the study of human speech. So for this one, know the definition for phonetics, of course, and know what your main articulators are. It's pretty straightforward. If you just think about the parts of your body you have to move to make noise out of your mouth, then those are the things that you're going to think of primarily. All right, so sound originates from the vibration in the vocal folds. We know that now. But as we start manipulating them with our articulators, we have our resonating chambers as well. And the resonating chambers function to give your voice its human and individual quality. Your voice sounds the way it does because of your larynx, specifically because of the resonating chambers that your body possesses. So the main resonating chambers that we want to know for sure, the pharynx, the mouth, the nasal cavity, and the paranasal sinuses. Again, the pharynx, the mouth, the nasal cavity, and the paranasal sinuses all act as the resonating chambers. Whispering is accomplished by closing everything except for the posterior portion of the glottis. So I always just whisper that so I don't have to study it, because if I ever only whisper it, it's going to stick. All right, the epiglottis is a large leaf-shaped portion of cartilage, and it really does kind of look like a leaf. And what it does, it moves to cover the glottis, to cover that airway, that opening in between my vocal folds. And when it covers it, then any food or liquid has to get routed into the esophagus, because we've closed off the trachea, the larynx at that point. So the only other option food or liquid has is to go down the esophagus. And so that is how we're able to keep food and liquids out of our lungs for the most part, is thanks to the epiglottis, a leaf-shaped piece of cartilage. All right, so here's some good pictures for the practical exam showing us some of the various components here. I've got my epiglottis at the top. You can see in the anterior or the posterior view. The posterior view is much easier to see, but you can kind of see how it does actually look like a leaf. My hyoid bone at the top, my various cartilages that we'll talk about in a moment, and then my tracheal cartilage at the bottom. I wouldn't worry too much about the thyroid or the parathyroid. I don't think that's something I would ask about, but I would absolutely know the various cartilages and the epiglottis, hyoid information on this slide. All right, so if we look a little closer at some of these cartilages, I've got my thyroid cartilage. This is also known as your Adam's apple, and it forms the anterior wall of your larynx. So this is the very front of your larynx, and it gives it a triangular shape. So if we look at our picture here on the anterior view, clearly the thyroid cartilage is the biggest piece of cartilage there. So it makes sense that that's the Adam's apple, the biggest one, the thyroid cartilage. Now, beneath that, really kind of on the back side, if we jump over to the posterior view, I've got my arytenoid cartilages, and there are two of them. They form joints. They have a wide range of motion, which becomes important for voice production. So with arytenoid, I always think of arachnoid because they kind of look like little spider fangs to me. And so when I see that, I think, oh, the spider fangs, arachnoid, arytenoid. I can make that leap. And then we got our cricoid cartilage that we're going to find under our thyroid cartilage or below our thyroid cartilage. And this is the landmark for a tracheotomy. So if you have to do an emergency tracheotomy because someone's airway is blocked, that is what we're aiming for, that cricoid cartilage. All right, into the trachea. The trachea, of course, is your windpipe. It's about 12 centimeters long. It's going to go from the larynx down to T5, or that fifth thoracic vertebra, where there it's going to split into my left and right primary bronchi. We've got 16 to 20 C-shaped or horseshoe-shaped cartilaginous rings stacked on top of each other to help prevent that trachea from collapsing. We have a trachealis muscle that lets us just barely change or subtly change the diameter of the trachea during inhalation and exhalation. At the very bottom of our trachea, it splits into my left and right primary bronchi. Right there where it splits, we have the carina. So this is just a projection of the inferior most tracheal cartilage. It is super sensitive, and if anything touches it, it triggers an immediate cough reflex. So that's where we see people swallow something and it goes down the wrong hole and they immediately start coughing it back up. It's because it touched their trachea or their carina and triggered that immediate cough reflex. You have no defense against it whatsoever. All right, then we move into as we move past the trachea, we move into our primary bronchi. So here's where we make the split and head into the individual lungs. So we can see it in our picture in yellow. That is my primary bronchi. So primary just means one or first. And so we can see how it moves. This is the first bronchi, and it's the main one, and leads into each lung. Now we do want to make note that the right primary bronchi is a little bit more vertical and a little shorter than the left one is, so making it more likely that if a foreign object does make it past the epiglottis and it does make it down past the carina, it's more than likely going to end up in our right lung because of the shape of that right primary bronchi. So upon entering the lungs, our primary bronchi split into my secondary bronchi. Our secondary bronchi we also called lobar bronchi because each lobe of the lung gets its own secondary bronchi. So we go primary into secondary, and the secondary leads into each individual lobe on the lungs. But my lungs are not created equal. On the right side, I've got 3 lobes. On the left side, I only have 2 lobes. So then once we get into the individual lobes, our bronchi start branching again, and our secondary bronchi branch into tertiary bronchi, and then our tertiary bronchi branch into bronchioles, and then they branch and branch and branch until we end up with our terminal bronchioles, which mark the end of the conducting zone. So we refer to all of this branching as a bronchial tree. A bronchial tree. So we can kind of see that in our picture here. If we were to flip this picture upside down, then it would really look like a tree. But we're looking at it upside down. So we got our trachea into our primary, then we move into our secondary, etc. And I put a layout here on the left that shows you each of the individual splits or divisions as we make our way through the lungs and through the respiratory system. Another good picture showing a little bit more detail here when we start adding in the lung tissue, the diaphragm, all of that stuff as well. Do make note of the cardiac notch that's coming up here in just a second. So in the middle on the bottom, we can see how we have a little piece of lung removed here. And that's just to make room for the heart. We refer to that as the cardiac notch. All right, into the lungs. Paired thoracic organs. The base is concave and sits over the diaphragm. The apex extends to just above the clavicles on each side. And we actually call lung tissue parenchyma. Parenchyma. That's what we call lung tissue. The hilum is kind of that central area. Everything that needs to get into or out of the lungs has to travel through the hilum. And there's the cardiac notch. So we can see it in this picture as well on the right-hand side. Not nearly as impressive as that previous picture we looked at. But there's the cardiac notch. It's just an indentation in the left lung where the heart sits. That's pretty easy. We can probably gather that from just the phrase cardiac notch. But what we also want to know is that because of this, our left lung is about 10% smaller than the right lung. Left lung's about 10% smaller than the right. The right lung's a little shorter because the diaphragm is higher on the right side because the liver is right there kind of pushing that right side lung up. So it's shorter, but it's 10% bigger than the left lung is. So we got some fissures to talk about. I've got my oblique fissures. So both lungs have an oblique fissure. Remember, oblique just means diagonal. And we can see how we have a diagonal fissure cutting up each of my two individual lungs. On the left lung, it's the only fissure I've got. So that means I've got my oblique fissure on the left lung, and then I have a superior lobe and an inferior lobe. On the right lung, though, I've got an oblique fissure and I've got a horizontal fissure cutting across horizontally, and that leaves me with a superior lobe, a middle lobe, and an inferior lobe to my left lung. Right lung, to my right lung. All right, bronchopulmonary segment. Segment of lung tissue that each tertiary bronchus supplies. So we traveled down, we said we got our trachea into my primary bronchi, into my secondary bronchi. When the secondary bronchi branch, they turn into my tertiary bronchi, and that's what we're looking at. It's all kind of color coordinated for us to make it nice and easy for us to see on the actual lung pictures at the bottom where each of those tertiary bronchi actually supply. What part of the lungs is it going to? And it's just an interesting picture, I think, to see how it all starts to come together for us. Each of these bronchopulmonary segments of the lungs made up of many small lobules. Each of our lobules are wrapped in elastic connective tissue and contain a lymphatic vessel, an arteriole, a venule, and a branch from the terminal bronchiole. So let's keep in mind what we are finding wrapped around a lobule, because that's going to be important later on when we start doing this gas exchange. And we can see in our picture how tightly wrapped around the lobule a lot of these vessels are. So we've got a lymphatic vessel, 1, 2, an arteriole, 3, a venule, and 4, a branch from the terminal bronchiole is what we find in our lobules. Now, each terminal bronchiole divides into microscopic branches now that we call respiratory bronchioles, and they've got our alveoli budding from their walls. This also is the first part of our respiratory zone. We've got an alveolar sac with 2 or more cup-shaped alveoli sharing a common opening, and each alveolar sac is surrounded by a pulmonary capillary. So a couple of cell types to be familiar with our respiratory system. I've got my type 1 alveolar cells made up of simple squamous epithelium, and these are the main sites of gas exchange. Main sites of gas exchange, my type 1 alveolar cells, simple squamous. Type 2 alveolar cells are also known as septal cells, and they secrete alveolar fluid with surfactant. And the surfactant helps lower surface tissue so our lungs, our alveoli specifically, don't stick together as we inhale and exhale. We don't want our lungs sticking together, so we use our type 2 alveolar cells, or septal cells, and the surfactant that they secrete. And then we also have alveolar macrophages, just wandering macrophages, getting out any dust, debris, pollen, whatnot that does make it all the way down into our lungs. They're there to help clean that up. So know the 3 types of cells that we associate with the alveoli and what makes each one of them different. So great picture for the practical exam, going all the way from the terminal bronchi down into the individual alveoli. So let's make sure we pay some attention to that. All right, so the exchange of oxygen and CO2 takes place by diffusion across our alveolar and capillary walls, which together make the respiratory membrane. So be clear on that. Our respiratory membrane, even though it's very thin, only half a micrometer thick, it's actually made up of the alveolar wall and the capillary wall together, where they rub up against each other. That's what we call our respiratory membrane. Now, the lung contains about 300 million alveoli, giving us a surface area of about 750 square feet of just for gas exchange. So that's a huge area. And we can see in our picture, that's actually about 1/2 of a tennis court that our body devotes to just gas exchange, moving oxygen in and carbon dioxide out. All right, so I kind of broke it down here all on one slide, separating my conducting zone from my respiratory zone, so you can see the various components when it's both written out for you and when it's drawn out in the picture. So know this one specifically. This is a great kind of starter slide just to start listing it over and over and over again until you can put this in order. All right, so now that we know all of the components of our respiratory system, let's get into the physiology behind our respiratory system. How does it actually work? So we've got three major steps in the process of respiration. One is pulmonary ventilation, two is external respiration, and three is internal respiration. So that's the first thing you need to know about the process of respiration. What are the three steps? Pulmonary ventilation, external respiration, and internal respiration. Now, first up is pulmonary ventilation, and there's four parts to actual pulmonary ventilation. Pulmonary ventilation is breathing, breath in, breath out. So the four steps: contraction of the diaphragm and external intercostal muscles. This is going to allow us to expand the lungs. Air will move down a pressure gradient, and then contraction of these accessory muscles as we try to make the lungs bigger to get in more air. So what are the four steps to pulmonary ventilation? A, B, C, D right there, all nice and easy for us. With external respiration, we want to know the AKA is also called pulmonary exchange, and internal respiration is known as tissue exchange. So lots of good stuff on this slide. We're going to look at all of this in a little bit more detail right about now. So step one in respiration. Remember, respiration is just the process of breathing, inhalation followed by exhalation, and there are four parts. Contraction of the diaphragm and external intercostals. Let's start with that. So what we want to know with step A in pulmonary ventilation is with the diaphragm. One, it's the most important muscle of inhalation. Two, it's innervated by the phrenic nerve. And three, it is responsible for about 75% of the air that moves into your lungs. So the diaphragm is a huge player in our respiratory system. Most important muscle of inhalation, phrenic nerve, 75% of the air. Our external intercostal muscles, they pull the ribs up and outward, and that's going to increase the size of our thoracic cavity. That's going to give us a little bit more room. With a little bit more room, we can pull in a little bit more air, and it's going to be responsible for the other 25%. So it pulls the ribs up and outward, increasing the size of the thoracic cavity, and is responsible for 25% of the air. So no diaphragm, no the external intercostals, and be able to recognize them in a picture, because these are also marked for the practical. Step B in inhalation. Expansion of the lung is going to decrease alveolar pressure. So as we increase the size of our thoracic cavity, our lungs get bigger, and as they get bigger, the pressure inside of our lungs drops. When the pressure drops, that helps pull air from the atmosphere into our lungs, because air is always going to choose the easiest path. That's the easiest path, the path of least resistance. And as we make our lungs bigger, that makes it easier. This lines right up with Boyle's law. Boyle's law tells us that the volume of gas varies inversely with its pressure. So the higher the pressure, the less volume of gas you're going to be able to move in. The lower the pressure, the higher volume of gas you're going to be able to move in, because it varies inversely. Step C, air moves down a pressure gradient into the lungs, so it just moves towards the region of lower pressure. Less resistance, that makes sense. And step 4, other accessory muscles help further increase the size of our thoracic cavity during deep, forceful inhalations. So with step D, we only ever use during deep, forceful inhalations. That's when we're taking that big breath in, because we're going to blow out some candles, or we're going to scream across the room, or we're going to try to blow up a balloon or something. And we need the air to do so. So that's the deep breath in. When we take that deep breath in, then we activate these accessory muscles. First is sternocleidomastoids, or SCM. That's the big muscle on each side of your neck. Comes down and attaches to the manubrium. So when it contracts, when it gets smaller, it's going to help elevate the sternum. We've got our scalene muscles, the three little muscles that run together on each side of your neck, and they come down and attach to the first two ribs. So when they contract, they're going to pull those ribs up and make them expand a little bit, so give us a little bit more room. And then we have pectoralis minor. which we can see in the bottom picture here. And it comes down and it's going to attach to ribs 3, 4, and 5. So when it contracts, it's going to elevate those ribs. And all of these working together help kind of just expand the thoracic cage to give us more room so we can take that deep breath in. So we have room for all of the air we're about to breathe in. Exhalation is a passive process because no muscle contraction is required. It happens because of elastic recoil, like stretching a rubber band. You let go of it, it's going to bounce back to its original size. Our lungs kind of have that same tension to it. If we expand our lungs out and stretch them, then when we exhale, our lungs pop back to their original size, and it's that tension as they close that helps push air back out of our lungs, accompanied with the weight of our chests. Now, forced exhalation is an active process because with this we use our abdominal muscles and our internal intercostal muscles. So our abdominals and internal intercostal muscles, and this is for the act of actually blowing up the balloon, of pushing that air out of your mouth, out of your lungs, into that balloon against pressure. That is going to be an active process because we are pushing against pressure at that point. All right, step 2 in respiration, also known as external respiration, also known as the net pulmonary gas exchange. And so with this one, we're moving oxygen out of from the alveoli in our lungs to the erythrocytes in our capillaries, and moving carbon dioxide from the erythrocytes to the alveoli of our lungs, and this will convert oxygen-poor blood into oxygen-rich blood. So what that's really telling us, external respiration, net pulmonary gas exchange, all we're doing is taking air out of the lungs and putting it into the blood. And at that same time, we're going to take the carbon dioxide out of the blood and we're going to put it back into the lungs so we can breathe it out and get rid of that waste product. So that's all we're doing. With pulmonary gas exchange, it's just gas exchange at your lungs. Out of the lungs, oxygen out of the lungs into the blood, carbon dioxide out of the blood and back into the lungs. And that's the entire step 2 of respiration. We're just oxygenating the blood. Step 3, internal respiration or net tissue gas exchange. We're going to move the oxygen out of the blood and give it to the individual cells that are dependent on our bloodstream for their oxygen. We are also going to move any waste products like the carbon dioxide out of these cells and put it back in the bloodstream so we can take it back to the lungs to get rid of it. So this is going to convert oxygen-rich blood into oxygen-poor blood because we're giving all of our oxygen away to these cells. And a picture here just kind of showing us the whole process from beginning to end as we make our way around, and how we take oxygen out of the lungs and put it into the vessels, and then we deliver it to the cells, and then we go back to the lungs, having to make pit stops along the heart in the process to help drive this whole process along. So oxygen transport. Body has 2 main ways to transport oxygen. 1, a small amount, a very small amount dissolved in the blood, specifically in the plasma. Most of the oxygen, 98.5%, gets transported temporarily bound to hemoglobin, but specifically to the hemi portion of hemoglobin, and even more specifically, it's going to combine to the atoms of iron that we find in the hemi portion of hemoglobin. So every hemoglobin molecule can hold up to 4 atoms of iron. Each atom of iron can grab 1 molecule of oxygen. So if we say a hemoglobin is fully saturated, that means every iron in the hemoglobin has an oxygen attached to it. Carbon dioxide is transported in 3 main forms. Again, the smallest percent by far is dissolved in the blood plasma. 23%, so almost a quarter of it, is bound to hemoglobin, but now it's the globin portion of hemoglobin. So the hemi portion is carrying oxygen, the globin portion is carrying carbon dioxide. But the big one you need to know for the transportation of carbon dioxide is through bicarbonate ions, HCO3 negative, and it's going to be about 70%. So the greatest percentage of carbon dioxide in the blood is carried in bicarbonate ions. lung volumes and capacities. So before we get into this too much, we need to understand that at rest, the average adult is going to average 12 to 20 breaths per minute. And each inhalation and exhalation is going to move about 500 milliliters of air into or out of the lungs accordingly. We use a spirometer to measure the volume of air being exchanged, and the record produced from the spirometer is called a spirogram. So the first volume that we want to be familiar with is the tidal volume, and that is the 500 milliliters of air that we breathe into and out of the lungs. So this is essentially the volume of air in one breath. We breathe in, we breathe out, the tide comes in, the tide comes out. It's just your normal breathing in and out. That is the tidal volume, and it is always about 500 milliliters. So this is one of two steadfast numbers that we have in our lung volumes. Tidal volume, 500 milliliters, the volume of air in one breath. Then with that information, once we get the breathing rate, then we can figure out the minute ventilation. So this is just how much we're breathing in a minute. So it's your breathing rate, 12 to 20 breaths per minute, times the tidal volume, which is always 500 milliliters. So for our example here, if we have a patient who's taking 12 breaths per minute, we can multiply that by 500, and that's going to get us to about 6 liters of air a minute. Exhalation. All right, next up we've got our inspiratory reserve volume. This is just any additional air during forced inspiration. So you take a normal breath in, and then we measure how much more air we can breathe in after that normal breath. The expiratory reserve volume is the same thing. Additional air during forced exhalation. So take a normal breath out. Now breathe out even more without taking a breath in, and that's what we'll measure as your expiratory reserve volume. The residual volume, just the volume of air remaining in our alveoli and airway after forced exhalation. And this is the other steadfast number. This one's always going to be about 1,200 milliliters. So residual volume, know the definition here, volume of air remaining, and it's going to be about 1,200 milliliters. And then we get our anatomic dead space, air remaining in the conduction zone. So that's going from our nose down to our terminal bronchioles, that does not undergo gas exchange. So it just didn't make it far enough down or make it far enough out to undergo gas exchange. Our lung capacities. Next up, we've got our inspiratory capacity, the volume of air that can be inspired following a normal, quiet expiration. So a normal breath out. Now, how much can we breathe in? Functional residual capacity, the volume of air remaining after a normal breath. Vital capacity, the maximum amount of air that can be exhaled after maximal inhalation. And then our total lung capacity is just the volume, the maximum volume of air that the lungs can hold. So lots of lung capacities. Don't get caught up on this too much, but absolutely know the definitions for all of these. All of these are great questions. So here's our spirogram. And now we've added in all the little bells and whistles, and so we can see how the various lung volumes roll out here if we look at our spirogram for a moment. All right, modifications of respiration. Some mechanisms adjust breathing to meet changing metabolic demand. The big one here is cerebral cortex. This will voluntarily alter your pattern of breathing to what you're doing. Voluntarily alter your pattern of breathing, the cerebral cortex. So we have a limited ability to hold our breath, but that will eventually get overridden by chemoreceptors, and our brain will kick in. And our cerebral cortex can also be influenced by the hypothalamus and the limbic system, affected by emotional stimuli. So we all breathe funny if we're laughing too hard, or we breathe funny if we're crying too hard. And that comes back to the emotional stimuli through our hypothalamus limbic system influence on the cerebral cortex. Bless me. All right, chemoreceptors. Sensory neurons responsive to chemicals. We have two types. I've got my central chemoreceptors that we're going to find in our medulla oblongata. They're going to respond to changes in cerebrospinal fluid. That just makes sense. If you think central chemoreceptors, remember, we think the central nervous system, central for central. And so with this, Our central nervous system, as always, is just our brain and our spinal cord. The medulla oblongata, of course, is part of our brain, so that's where we're going to make that association. And it responds to changes in cerebrospinal fluid, which your brain and spinal cord actually float in, your central chemoreceptors. The other one is the peripheral chemoreceptors. So now we're moving away from that brain and spinal cord. And we're going to find our peripheral chemoreceptors in the aortic bodies and the carotid bodies. So the aortic and the carotid, of course, are vessels. And so our peripheral chemoreceptors respond to changes in blood. So you need to know where we find our central chemoreceptors and what they respond to. Where do we find our peripheral chemoreceptors and what do they respond to? All right, respiratory acidosis. Decrease in ventilation causes an increase in carbon dioxide concentration and a decrease in blood pH. Respiratory alkalosis, an increase in respiration, increases blood pH beyond that normal range. And just remember with the pH scale, the lower the number, the more acidic the solution is. All right, so before we get into the final part of this, into the pathologies, we have two basic types of classifications for pulmonary disorders. One is restrictive pulmonary disorders, and this is what's going to limit the lung's ability to stretch. So with that, we are really talking about compliance. How much effort does it take to stretch your lungs? How hard is it to take that big breath in? So high compliance means that the lungs expand easily. Low compliance means your lungs don't want to stretch out like they should. And we see this in certain conditions like tuberculosis or emphysema where we lose some of the stretchiness to our lungs. But on a spirogram, if all of our lung volumes and capacities come back reduced, then that's going to make us think, okay, we've got some sort of restrictive pulmonary disease going on. And then we can start looking at the restrictive stuff a little closer and see if we can't figure out. 2. Are obstructive disorders. So this is where the walls of our airway offer resistance to airflow caused by anything that narrows or obstructs our airways and increases resistance. With this one, we see it in conditions like asthma, COPD, or bronchitis. And with obstructive disorders, all of our inspiratory volumes come back normal, but our expiratory volumes are all reduced. So normal inspiratory, reduced expiratory, then we're going to think this is an obstructive disorder. All right, 2 pathologies. All of these pathologies are fair game for the practical, so make sure you're looking at these. First up is asthma, a condition in which your airways narrow and may produce extra mucus. This can make breathing difficult and trigger coughing and a whistling sound that is like a wheezing when you exhale, when you breathe out. We'll get a little whistling effect most of the time with asthma. Bronchitis, inflammation of the bronchi, essentially is what this is. It is often associated with a productive cough. So you're coughing and you're coughing something up out of your lungs, then we're going to think, oh, that is a symptom of bronchitis. And with bronchitis, if we look at the plain film on the right here, what we can see, if we look at this in all the detail, we can make out a lot of these bronchi. We shouldn't be able to see most of them. So when it shows up on an x-ray, that tells us, hey, we've got something going on. Something's building up inside of these bronchi to where they're going to show up as vividly as they are on these x-rays. Pneumonia. Inflammatory condition, can be bacterial or viral, but typically with pneumonia, the big thing, it is localized to a lobe on the lung. So we know our left lung has 2 lobes, our right lung has 3. So if we see a lot of congestion in one of those lobes, then we're going to think this is probably pneumonia. Emphysema damages the walls of the alveoli specifically, and this creates just one big air space instead of a bunch of small ones. So a bunch of small ones give us more surface area because we can do gas exchange along the linings of all of these individual walls. So when we just have one big one, we don't have nearly as much surface area as we normally would. And so with emphysema, we practically destroy our alveoli, and that leaves us with big gaps and less gas exchange going on. And emphysema is a type of COPD. Tuberculosis, Bacterial, characterized by these growth of nodules or tubercles in the tissues, especially the lungs. So tuberculosis is pretty easy. They almost look like little burrs to me, like little sand spurs or something along those lines inside your lungs. So these are our tubercles, hence the name tuberculosis. So this one's pretty easy to spot. And lastly, we have the pneumothorax, which is just the term for a collapsed lung. So if we jump over and look at the x-ray here, you can see we've got a marker on this film in the upper left-hand corner, marking that as the right side of the patient. So on the opposite side, if we look at the lung field there, we can see lots of little bronchi and bronchioles kind of spread all throughout. Nothing's really standing out too crazy to make it look like bronchitis or anything. But on that right side, if we go back over there, we can see there's nothing kind of in between these ribs. There's no lung field whatsoever. It's all kind of collapsed, hanging out across from the heart. This happens most of the time when air starts to get into the thoracic cavity in between the lung and the tissue. And as the air starts to build up, it puts enough pressure causing the lung to collapse. And it could be from trauma, or it could just be for no reason at all. A lot of times this just happens, and we don't know why. But symptoms typically include sudden chest pain and a shortness in breath. And that is a pneumothorax. Just be able to recognize it. Be able to recognize some of these x-rays in this pathology section, because you will absolutely see them again on the practical exam, saying, hey, make a diagnosis. All right, so that's it for our respiratory system. Good luck.